He also has professional interest in healthcare quality, patient safety, and clinical epidemiology. He's very passionate about improving health outcomes for patients using evidence-based strategies. Dr. Ogbonnaya is a fellow of the West African College of Physicians, as well as a fellow of the International Society for Quality in Healthcare. He also holds a Master of Applied Science in Patient Safety and Healthcare Quality from Johns Hopkins University. He also has a diploma in infection prevention and control, as well as a Master of Public Health from the University of Lagos. He is a certified professional in healthcare quality and currently the head of community medicine department at FMC Umuahia. He's also a senior lecturer at Gregory University College of Medicine, Umuahia. So we make welcome Dr. Godswill Ogbonnaya.
Thank you very much, Dr. Joan. And good afternoon, everyone. I will have to request the admin to permit me to share my screen. Okay, I think I already have that permission to do so. Please permit me to have my video off because of network instability. Let me start by appreciating the Nigerian Society for Infection Control for giving me the privilege to make this presentation. And also want to thank my teacher at the Diploma Infection Prevention and Control some time ago. That's Dr. Showande. I can see her in the participant list. I also want to appreciate Professor Bunshola for the sacrifices she made to put IPC in the center of discourse in Nigeria today. And not forgetting our own Tochioko, the NCDC and our team for all the good work they are doing in IPC. And my colleagues, all the IPC focal persons and practitioners who are here present, I sincerely appreciate our connection and our collaboration and knowledge sharing. It's helping all of us to grow in the profession. So I'll be taking this session on hand hygiene audits in healthcare facilities. That's my outline for the presentation, and I'll follow it systematically in the next few minutes. So by the end of this session, participants should understand my 5 moments for hand hygiene concept, which is really the focus of hand hygiene audit. Define healthcare zone, patient zone, and point of care, which represent geographic conceptualization of transmission risk within the healthcare facility. Define hand hygiene audit, and then understand how to implement a hand hygiene audit in their facility. I will introduce this session by stating this quote from Martin Rubin. We state, every line is the perfect line if you don't measure it. And Peter Drucker also said, you cannot improve what you don't measure. The importance of this statement to our current situation is that we are doing a lot in IPC, if you ask me, based on some of the achievements that we keep hearing from all the centers. But we are not measuring it. So while we keep beating our chest and saying that we are doing well, we may appear perfect in our eyes because we are not actually measuring what we are doing. And like Peter Drucker states, you cannot improve what you don't measure. So we cannot really say we are improving in our IPC endeavors, or we are reaping the dividends of our IPC efforts if we are not measuring what we are doing. I think hand hygiene has to do with measuring what we are doing, measuring our performance regarding hand hygiene. The WHO has identified hand hygiene as a key performance indicator for national IPC programs. That's to tell us how important hand hygiene is. And hand hygiene falls within the check it domain of the IPC multimodal improvement strategy. We know about the 5 components or domains, if you will. Build it, teach it, check it, sell it, and then leave it. That's system change, health education, monitoring and feedback, promotion, and then, of course, the culture change. So hand hygiene falls within that, the checking domain. That means it's a very, very important aspect of our IPC programming. And of course, if you look at the stepwise hand hygiene improvement strategy that has 5 steps, hand hygiene audit also fall under step 2 and step 4, which is baseline evaluation and follow-up evaluation. So you can see that hand hygiene is interwoven in everything IPC. But when you look at our situation in the country, I say that measurement of hand hygiene compliance appears to be a weakness in our national IPC program, because from our conversations with my colleagues and what we see, we are not really measuring hand hygiene compliance, which is basically the fulcrum of this presentation. So this is my way of defining hand hygiene audit. That it is a quality improvement activity that seeks to improve the safety of healthcare by determining the compliance with recommended guidelines for hand hygiene by healthcare workers, and using the audit result to guide decisions about hand hygiene promotion, education, and training. If you look at this definition, hand hygiene audit is clearly a quality improvement activity that aims to contribute to the improvement of safety of healthcare. I want to know whether people are doing the right thing, following guidelines. And not only that, after the audit, what next? You want to use your result to guide decisions on how to promote hand hygiene, how to educate and train frontline workers. So what is hand hygiene? Just briefly, we know hand hygiene is any action that is carried out to remove dirt, debris, soil, or reduce both transient and resident flora on the hands by using soap and running water or an alcohol-based hand rub. Of course, there are different methods of hand hygiene. We know of hand washing, hand rubbing, surgical and scrubbing, and there are other methods that use all forms of wipes, antiseptic wipes, just to ensure that the hands are clean. So why is hand hygiene important in this discourse? There is ample evidence that it is the single most important measure to prevent the transmission of infections in healthcare facilities. There are several studies that have generated that evidence. And hand hygiene remains the backbone of infection prevention and control. Just like I said, the WHO states very clearly that hand hygiene is a key performance indicator for national IPC programs. And of course, within the Orange Network, it has been adopted, hand hygiene has been adopted as our process indicator. So we must take steps to begin to measure hand hygiene. And hand hygiene also have been shown in areas of non-compliance where studies have been done that is responsible for most of the outbreaks in our health facilities, that is healthcare-associated infections and the spread of multi-drug resistant organisms. So let's talk about concepts of hand hygiene in healthcare setting, because that will guide us towards understanding how to carry out hand hygiene audit. Let's start with 5 minutes of hand hygiene. This is a concept by WHO that refers to the points in time when hand hygiene should occur in order to prevent the transmission of healthcare-associated infections. It's a specific point in time when a healthcare worker should perform hand hygiene. And why is it so? Because it proposes a unified vision for those who are going to train, for those who are going to observe, and for the healthcare workers to facilitate education. So that when we are training people, we are training them on the same concept. They are knowing what is expected of them. And measurement in somewhere in Abuja, or somewhere in Asaba or in Lokoja will all be measuring the same thing. So if we don't understand the 5-moment concept, all of us. Then what I measure in Wire as my compliance rate cannot be compared with what another colleague measures in maybe another facilities as their own compliance rate. So we want to make sure that everyone is measuring the same thing. And not just that, we do not want, if I say I have a 20 opportunities and that person do the same activity, he will say it's 50 opportunities. We want everyone to be on the same page. That's why this concept was created, so that everyone will be doing the same thing. So the moment, again, this is just a review for most of our focal person. We all know it: before touching the patient, before clean or aseptic procedure, after potential exposure to blood and body fluids, after touching the patient, and after touching the patient's environment. And of course, each moment is a potential source of contamination for the healthcare workers' hands. May I also mention here that it has proven over time that the hands of healthcare workers is the most important vehicle of infection transmission within healthcare facilities. So let's also look at the concept of indication and opportunities, because by the time we start talking about calculating compliance, you want to identify what's an indication, you want to identify what's an opportunity. An indication is the reason why hand hygiene is necessary at a given moment and is justified by a risk of germ transmission from one surface to another. So whenever there is a contact, maybe before touching the patient, there is a risk of germ transmission from the hand of the healthcare worker to the body of the patient. And there's also a risk of contamination of the healthcare worker's hand from whatever microorganisms that were present on the patient's body. So you see that there's always a risk of contamination of surfaces when there is contact. So an indication is the reason why hand hygiene is necessary, because there's a risk that germ transmission has occurred. And then an opportunity is the moment when hand hygiene action is necessary. I will emphasize during healthcare activities to interrupt germ transmission by the hand. So in other words, when there is an indication, when hand hygiene is necessary for you to perform hand hygiene, then you want to ask yourself this question: since if my hands are contaminated, what will I do to stop or interrupt germ transmissions by my hand? So that provides an opportunity for the healthcare worker to take an action. And that action is what will break or interrupt the transmission of microorganisms. So whenever there's a risk of transmission, it creates an indication for hand hygiene, a reason why hand hygiene should be performed. And once that is taken as an opportunity to interrupt transmission, it results in an action, which could be hand rubbing with an alcohol-based hand sanitizer, or hand washing with soap and running water. So that's about indication and opportunity. And a hand hygiene action must correspond to each opportunity. That is how compliance is calculated. As we'll see as we progress, multiple indications may come together to create a single opportunity. So let's talk about the healthcare area and the patient zone. The patient zone includes the patient and some surfaces and items that are temporarily or exclusively dedicated to the patient. You know, that includes all the inanimate surfaces, like you can see in the picture there, the drip stand, the site locker, the rails, you know, everything that may be in direct physical contact with the patient, including the patient, constitute the patient zone. While the healthcare area contains every other surface, all the other surfaces in the healthcare setting, outside of this particular patient we are looking at now. So that includes every other area in the healthcare setting. All other patient zones now constitute the healthcare zone. Why is it important to have this geographical conceptualization of transmission risk? We know that patients shed a lot of squams that contains viable microorganisms every day from their normal skin. I read an article that says about 1 million every day. And of course, the hands of healthcare workers will pick these microorganisms and of course take them to other patient zones and also contaminate surfaces within the healthcare environment. So the healthcare zone is heavily contaminated with germs, multi-resistant organisms from all the patients within that particular healthcare setting. So this geographic conceptualization of transmission is very, very important. And also, you should also know that our hand hygiene observation will focus on what is happening in the patient zone. And the patient zone is not just a static concept. Wherever the patient is becomes patient zone. So whether the patient is on admission or in a clinic or in an injection room, wherever the patient is, he carries himself and every other thing that is temporarily or exclusively dedicated to him or her with him. So that becomes patient zone. So the patient zone is not a static concept. It can be anywhere. And that takes us to the next, which is the point of care. So the point of care is the point where three elements occur together within the patient zone. That's the importance of the patient zone, because that will be the focus of our hand hygiene observation and monitoring. So the patient, the healthcare worker, and the healthcare activity. Be anything, it could be setting the line, it could be taking a blood pressure, it could be checking for palo, whatever healthcare activity is going on. But for you to define point of care, the patient, the healthcare worker, and the healthcare activity being provided, being undertaken at that particular moment must be present. So at the point of care, there's need for hand hygiene to be performed there where care is being provided. And the hand hygiene products should be accessible to the healthcare worker within an arm's reach. So the healthcare worker should not leave the patient zone in search of hand hygiene products. Hand hygiene products, hand sanitizer, the disposable towels, the water, so they should be accessible. That makes it easier for healthcare workers to perform hand hygiene. Now, this is a picture of example of hand hygiene products at the point of care. You can see at my right, extreme right, you can see pocket carried alcohol-based hand sanitizer. You can see the one that is mounted to the wall and another one at the bedside. So we can adopt this and make this provision in our various schools so that it will be easier for healthcare workers to practice hand hygiene at the point of care. So let's go to monitoring hand hygiene, which is actually what we want to discuss. Like we said, we want to monitor hand hygiene. The expectations for performing hand hygiene should be clearly defined and made known within the health facility. So what we expect the frontline health workers to do, it should be known to them. A lot of our staff don't even know what is 5 moments for hand hygiene. They don't even know that they ought to perform hand hygiene at the point of care. Some still believe that when they are done with their services, they have to leave that point, go to some far area in the ward, and then wash their hands with soap and water. So they need to know that. That is why it's very important for hospital-based policies on hand hygiene to be clearly, stated and made available to all workers. So let's look at the methods for monitoring hand hygiene. It could be direct or indirect. Direct observation by a trained and validated hand hygiene auditor is the gold standard, because we actually see what is going on and we're able to identify how hand hygiene is performed. And then You also have another direct method that's using patients, actually using patients to, to carry out the observation. So the patient makes observation and then, of course, reports. It's an inexpensive approach, but it might strain the relationship between the healthcare worker and the patient. And also, you might want to train the patients on how to recognize the moments for hand hygiene. So that's the problem with patient assessment. And when we talk about the indirect methods, we use the consumption of hand hygiene products, which of course is not very, very reliable because you cannot ascertain whether the hand hygiene product was actually used by the healthcare workers, because patients may also have access to it, to use it, and you will not be able to determine if the product that was used was actually used for hand hygiene. It could be stolen, people could take it away. It could be stolen, taken away. If I've observed that, or they may use the product for some other purposes. I've seen cases where workers were using our hand sanitizers to clean their desk. So if you want to use that to measure hand hygiene compliance, you may be making a very, very serious mistake. You may not be accurate in your compliance rate. So direct observation remains the gold standard, because it is very reliable, and then you can observe other important details, especially how was the hand hygiene performed, whether they are even doing it well. Though it's time consuming and may require skill worker, because you need to train workers to actually do the observation. Though it also has a problem like observation or observer bias or selection bias. Someone goes there and decides to pick on a particular healthcare worker who maybe is not performing very well, and use that to rate the entire facility. So it has its own challenges, but it's the best and it's a gold standard, and that is what we are recommending for use in our various facilities. So the hand hygiene audit is not an activity that the IPC focal person will just wake up one morning and say, I'm going to do audit. It's an activity that should be planned. So the IPC team, they made the plan, they decide the scope, they get their materials ready, then they go to where the action is taking place. That's what I mean by go to the chamber. They go to where the action is taking place and do direct observation. That's the auditors. Do the observation, record what they observe. And then, of course, after collecting the data, they come back, have their debrief, and then do the data analysis. And then, of course, provide feedback to all the stakeholders, the healthcare workers, managers, the head of department, as the case may be. So looking at the planning, it's very important that before you embark on an hand hygiene audit activity, you define the scope of the audit. What aspect of the hospital are you going to cover? You want to cover the entire hospital? Do you want to cover only the medical department or the surgical department? Which target group are you going to target, the nurses or the doctors? So those things should be defined. Then you now determine the timeline of all the audit activities, from the planning to data collection to post-data collection, to the time you're going to disseminate or provide feedback to the stakeholders. The timeline should be decided. Then, of course, I've talked about during the scope, you identify the service areas you want to go. For instance, if you say you want to go to internal medicine, they have many wards in the facility, they have many wards that is managed by the internal medical department. So what do? Decide whether it's going to be male medical, female medical. So you identify the particular service delivery areas you want to go for the audit. Then you communicate with those who are in charge of that delivery area. In our case, we call them ward managers. You want to reach out to them and tell them about what you're about to do. Then you identify your hand hygiene auditors. All of them, you might have a number of them, they are all trained, but not all of them may be available. So you identify those who will be available to do the job. And of course, you mobilize them, have a meeting with them, do a refresher training for them, and then go to the field, in this case the ward, and then do some practice and ensure that they are validated. That is, they can actually measure or audit hand hygiene practice while care is going on. Then you procure the materials you need for the audit. It's not on the day of the audit, you start looking for your hand hygiene forms, you start looking for pencils, erasers, and all those materials that are needed for the activity. So procure the materials and you get them ready before you go to the field. That's the plan. Then the next is, of course, if everything is ready, we are going for data collection. It's important to note that those who are going to collect the data must be trained and validated. They must be trained and validated. Cannot just take anybody to go and observe hand hygiene. How do you validate them? You must ensure that they have the skills to observe hand hygiene accurately. They are familiar with the five moments of hand hygiene. They are familiar with the facility-based hand hygiene or IPC policies, and they have been confirmed to do it well. In other words, you have trained them. Maybe you have used the simulation videos, and you are very sure that they can identify the indications, they can recognize the moments, and they can also record the appropriate or necessary hand hygiene actions. Now, when this is done, and you are very, very sure that you can do it, then you can move them into the wards. And there's another aspect of this validation is if you are going with two trained auditors, for instance, and you take them to the wards, both of them will observe the same healthcare activity and record their findings. And as the IPC focal person who is expected to really know about this, it will now be like the gold standard for whatever they get. So if by the time you have gone for that validation exercise and you are recording maybe 10 moments and auditor A is recording 6 moments, and then auditor B is recording 3 moments, then there's a problem. So you have to call them again together and discuss about that particular care activity, identify the gaps, and then repeat the same exercise with another healthcare activity. That's the process of validating the observers. It's very, very important. I really emphasize it because that was how we were trained, and that is how we have been training our own observers in my facility. And it's not an easy task, I must tell you. It is time consuming. It would drain your energy because you have to do the theory aspect maybe in a comfortable hall, and then you move to the wards to practice it. So direct observation is the gold standard. We mentioned that before. And during the process of taking the audit, there should be non-interference with ongoing work. The activity should be done openly and not interfering with the work. Don't interfere, just observe. And then there should be no assumption. What you didn't see, don't record. For instance, walk into a ward and you see a healthcare worker taking blood pressure. Of course, that's already touching the patient. And since you did not observe him or her do hand hygiene, don't say that, I look around, I didn't see hand sanitizer, so this person did not perform hand hygiene before touching that patient. It's not accepted. You are making an assumption. Wait, when the healthcare worker has finished the activity, you can now record what he did thereafter. Record your finding or observation form immediately. Immediately, you don't have to wait. Whatever you see, record immediately because you may forget. And then you observe individual healthcare workers. You don't observe, unless you have some experience. It's been recommended that you should not observe more than three healthcare workers. We recommend that for those who are starting, just observe one person. Then protect the identity of the observed healthcare workers because you will know them. So you protect their identity. You don't have to start talking about their compliance rate as individuals. It's not accepted. It's unethical. Of course, the hand hygiene form does not make provision for us to record the names or identify a particular healthcare worker. But since you work in that facility, you may know them. So you have to protect their identity. And of course, you need to respect the privacy of patients. So when patients, if there's a screen and they don't want you to come and intrude, please stay clear, look for other activity and observe. So that's about the data collection. And part of the data collection, we still talk about observation, and that is it there. It's not part of this conversation actually, but I had to bring this form here because it's very, very important in the audit process. You can see the form. The form is available for download at the WHO website, and the instructions are there Yeah, very, very easy to understand. So if you download this form, just read, you will see you will see the instruction behind it on how to complete the form. It's important to know that the form states the professional category, whether it's a doctor or a nurse. There's a code for each category, and there's a number you observe. Then if you look at the columns too, you will see you have the opportunity there. That is OPP. Sorry, I don't have a marker to point to that. You see OPP, you see indication, and then you see hand hygiene action. So the indications there are those moments for hand hygiene: before patient, for aseptic procedure, after blood and body fluid exposure, after patient contact, and after patient surrounding. So that is for the indication. So once you see this, you will be able to check as appropriate. We'll talk about that shortly. It's also important to know that there are times when you may have two indications occurring together to create one opportunity. Two indications occurring together to create one opportunity. This has often led to some sort of confusion among practitioners when we try to observe hand hygiene compliance. So there are cases where you can have two indications, one opportunity. Now I'll explain that. Remember, we said an opportunity is the action, is what you do to interrupt the transmission of germs or microorganisms from one surface to another. So sometimes after touching, like you can see in the figure there, after touching a patient, it is presumed that the hands are contaminated, and you're now moving to another patient. So the indication, the reason why you should perform hand hygiene is because you've touched a patient and there's a risk that your hands have been contaminated with the microorganism from that patient. So you are now moving to another patient. So what do I do? My hands have been contaminated. So that has provided an opportunity for me to clear those germs on my hands, so that by the time I get to the next patient, my hands will be free of germs. So while going to touch the next patient, that is another theoretical risk of transmission. So the next indication is before touching the patients. In this case, the germ you pick from patient A is still on your hands. So you are going to deposit it on patient B. So in between these two moments of indication, if you will, you need to take an action to interrupt the transmission of germs from patient A to patient B via your hands as a healthcare worker. So you need an action. So in this case, you only need one hand hygiene action that will take care of the two indications. So two indications provided one opportunity for you to interrupt transmission. That is just it. There are other scenarios which are, I think, for those of our IPC focal persons, we have access to the training video. There are other scenarios where multiple indications create one opportunity. So this is how it should be filled on the hand hygiene form. You can see the X mark there, before patient, after patient, and I put miss there just to say that maybe it's common in our facilities anyway, where workers move from patient A to patient B without performing hand hygiene. So if that hand hygiene action was not taken, you check missed. If you were hand rub, that is HR, that's the one who would have checked if the correct action was taken by the healthcare worker involved. So in this case, there were two indications, but one opportunity, and it was missed. That's what I recommend. Also, like we said, double, triple, quadruple indications can be observed. They might be observed during a healthcare activity. But after patients and after patients surrounding can never coincide in the same opportunity. The reason is very, very, in the same patient, it cannot just be, if it doesn't work, because whatever is in the patient is what is still in the patient's environment. So the two cannot coincide. For our IPC IPC focal person, they understand this perfect. So that's the only two situation. That's the only situation where two indications cannot create a single opportunity. From the observer point of view, one indication must be detected to create an opportunity. Of course, we have talked about multiple indications occurring together to determine one opportunity. It's very, very important. And then the hand hygiene action should also correspond to a counted opportunity. So if you detect an opportunity, then there should be a corresponding hand hygiene action. Because, like we said, the opportunity is what is done actually to interrupt the transmission of germs from one surface to another. It's just like, oh, now that my hands have been contaminated, so I have an opportunity to do something about it. I have an opportunity to break to break or interrupt the transmission of germs from my hand to the next surface. So what do? That will not give birth to the action. So whenever an opportunity is detected, there must also be a corresponding action. It could be a correct action, that is hand rubbing or hand washing, or an incorrect action, that is a missed action. The hand hygiene action is performed either by hand rubbing, or I mentioned that. An observed hand hygiene action not corresponding to an actual indication should not be recorded. For instance, if someone, maybe you see somebody, a healthcare worker walking along the corridor, performs hand hygiene, it should not be recorded because there was no indication for it. So this is how to calculate compliance. Compliance is calculated by dividing the performed hand hygiene actions. If you want to calculate a positive compliance, that is complying with recommended standards, then that will be the positive hand hygiene actions. The total number performed, divided by the required hand hygiene action, that is the opportunity. So the opportunities serves as the denominator in calculating hand hygiene compliance, while the hand hygiene actions taken serve as the numerator. They multiply by 100 to have your percentage. So that's about the data collection. Then lastly, we talk about the post data collection. Of course, once that has been done, the next thing is to debrief. You bring the team together, the auditors, and reflect on what has happened, what went well, what did not go well. And then you learn how to improve the next audit activity. So it's very, very important to bring all those who participate in an audit activity and discuss what happened. Thereafter, you want to review the completed hand hygiene forms, identify those where there are errors, and where maybe those like one I mentioned, maybe patient surrounding and patient after treatment surrounding and after treatment altogether. We identify all those errors where maybe an opportunity was identified or an indication was recorded, no action. So you make sure you clean the data and then you fill the summary form. There's another form, I'm sorry, I didn't project it here, that summarizes the opportunities, the actions taken, and gives you a total of the compliance. So it's a very, very simple way to present it, where you record the number of opportunity, the number of hand washing, the number of hand rubbing, and then you summarize it for each session, where the activity was taken, when the activity took place, you record for each session, and then you summarize and then get the total for the period of observation. So thereafter, after filling the summary form, you now analyze the data and then calculate your compliance rate, which you have mentioned in the previous slides. That is perform hand hygiene actions times the required hand hygiene actions times 100 to give you percentage. Then lastly, having calculated, you now have your compliance rate. The next, you want to write your audit report, where you present it with whatever happened with the audit, all the other obligations, including the ones that may not be connected with the direct of compliance. You package it together and then make your recommendation based on the result. It's possible to know which particular indication is often missed. That by the time you do subgroup analysis, it's possible. So if assuming while calculating your compliance, you now discover that most healthcare workers are not performing hand hygiene before touching the patient. So you want to think, how do we address this? So that is a very, very important aspect of the audit report. So you now know where to target your intervention. Or you discover that nurses are complying more than doctors. What do we do? You now know which target group to face. So you make your recommendation based on the results. Then, of course, feedback, you want to share findings with all stakeholders, the healthcare workers who were observed, the ward managers, the heads of departments, the CMACs, head of clinical sales and training, or the MD or the CEO as the case may be. So you want to share the findings with them and make your recommendation for them to, to support your work as an IPC corporate person. So let me go through the key points again. Hand hygiene audit is a quality improvement activity and is based on my 5 moments for hand hygiene. It requires proper planning to succeed. It's not an activity that should be undertaken anyhow. And it must be carried out by trained and validated hand hygiene auditors. The results should guide decisions about hand hygiene improvement. I think that brings, this is the last slide. Thank you so much for your attention. Thank you, and over.
A very big thank you, Dr. Godswill Ogbonnaya. I'm sure we can all understand why you are a quality control expert, a certified one, a globally certified quality control quality expert. That was a very good presentation, very clear, very precise, and you took us through all the very important points. I will crave the indulgence of all our attendees that have questions and comments to please hold them till after our second presentation. So just do well to jot down your questions and your comments so that you do not forget, so that I can take all the observations and comments at the same time. Well, I would like to invite Dr. Abimbola Adesanya, who is the IPC focal person for Federal Teaching Hospital, Lokoja, Kogi State, to take us through an IPC improvement project at her facility. So please, let's welcome Dr. Abimbola Adesanya. Can we have reactions for Dr. Ogbonnaya's presentation? Sorry, I forgot to mention that. That awesome presentation deserves a whole lot of applause. So let's hear.
Okay. Dr. John, can I go ahead? Hello?
Yes, please, you have the floor.
Okay. Good afternoon, everyone, my teachers, colleagues, and every other person present. I want to appreciate the ICANN Association and then the NSIC for this opportunity to present our improvements practice, quality improvement practice in Federal Teaching Hospital, Lokoja, Kogi State. My name is Abimbola Adesanya. I'm the IPC focal person of Federal Teaching Hospital, Lokoja. Sorry, my slide is not moving as it ought. I don't know why.
Dr. Abimbola, do we ask Mr. Likon to move the slides for you?
Okay, that'll be fine. That'll be fine. Okay, thank you. So I'll be using this outline, introduction up to conclusion. Next slide. So health-associated infection, like we all know, is occurring at high rates globally and even nationally within our facilities. And with implementation of standard infection prevention and control practices, a reduction in occurrence can be achieved. So one of the first line of defense to achieve this is environmental cleaning. And we know that in combination with other interventions, we can break the transmission pathways of healthcare-associated infections in health facilities. Next slide. Federal Teaching Hospital, Lokoja, it's a 305-bedded hospital. We have an IPC program with a committed IPC team who are working to sustain the best IPC practices in the hospital. But one thing we noticed during our usual rounds is that environmental cleaning is suboptimal, both in our wards and our clinics. So we noticed that cleaning is not done properly. Next slide. So we decided to carry out an improvements plan process on environmental cleaning. And while we were walking through, we observed that cleaning was done 3 times in a day, but yet the outcome was still poor. So the team now decided to find out the reasons why cleaning practices in the hospital was poor. So we asked the following questions. Next slide. We asked, are the healthcare attendants who clean the hospital trained on environmental cleaning? Is cleaning done properly? Are the right cleaning equipment and agents regularly provided? Is water supply constant? Are health attendants properly supervised when carrying out environmental cleaning? Are they provided with the appropriate personal protective equipment? And is hand hygiene practice amongst this group of healthcare workers? Next slide. So to answer these questions, next slide, please. Hello?
We can hear you.
Okay, you have jumped. There's a slide before this. Okay. So to answer these questions, we developed these objectives. To improve, our aim was to improve environmental cleaning practices in Federal Teaching Hospital, Lokoja, in order to prevent occurrence of healthcare-associated infections, promote a clean and safe environment for healthcare workers, patients, and visitors. So our objectives were to identify the reasons responsible for this poor environmental cleaning practice, to educate the healthcare attendants in the hospital, to ensure regular provision of the cleaning equipment, and also to develop a standard operating procedures and to provide posters as guide for the healthcare workers to achieve best practice. Next slide. So we began with a brainstorming session where we had a meeting with the heads of units. We all know that when it comes to cleaning of the hospital, the group of persons that supervise those that clean are the nurses. So the IPCT met with the heads of units to discuss why we're having these problems, this setback in cleaning our hospital. So we now, following our discussion, we brought up these possible causes. I'll just pick a few of them. We noticed that the healthcare workers were not adequately trained to carry out this activity. We noticed that the supply of the commodities were not regular. There were no SOPs, no posters. Then we also noticed that a number of the healthcare attendants were elderly, so they will not be able to carry out this function properly. Then access to this cleaning agent was also poor, because complaints was that once it is supplied to the ward, it doesn't get to them. And even if it gets to them, they just get a portion of these cleaning agents. And then increased sick coughs, poor hygiene practices amongst patients and staffs. Next slide. So other likely causes that we brought up from our discussions, I'll just pick a few from here, was insufficient funds. Then the one that most of them talked about were that staffs were not motivated. So we're not going to, we should not expect much out of them without motivating them to actually do what they are doing. And also that the cleaning agents supplied were the wrong ones, because the hospital runs, we all know, runs a procurement system where contractors will bring these cleaning agents, and nobody was allowed to come and tell them that these are the cleaning agents that are required to clean the hospital. So we now pen down all these problems, and we decided to carry out our interventions. Next slide. So here I was able to fix all the problems into this fishbone diagram. Like we all know, it's a quality improvement tool that we use for root cause analysis. And all the things I mentioned before, we are arranged according to the equipment, the process, the people, the method, environment, and even communication. And all these factors that you are seeing here are the reasons why we had suboptimal hospital environment cleaning. Next slide, please. Next slide. Hello. Hello.
On the next slide, please.
So reasons for poor practice. We're able to summarize into these 6 key reasons. That's the healthcare workers were inadequately trained. They were not motivated. The cleaning equipment was not supplied. Sorry. Hello.
We can hear you. We can hear you.
Can hear you.
Dr. Adesanya, we are hearing you, but I don't know whether it's me. I can't hear you anymore, but we can still see your slides.
Will it be on internet?
Hello.
We can hear you
I
now.
apologize.
We can hear you now. We can hear you
Yes.
now.
We can hear you.
Okay, ma'am. So the reasons, like I was saying, were inadequate training for the healthcare workers. They were not motivated to work, to carry out their duties. Then the supply of the cleaning agents were not regular. and the right ones were not being supplied. Then also supervision by cleaning was not there, and then faulty procedural steps. There is no access to cleaning agents by the health attendants. Next slide. Next slide. Hello?
Yes, we have moved to the next slide. Prioritization matrix.
Okay, thank you. So just like we were taught during the advanced classes, that during quality improvement, okay. Okay, thank you. So I said, just as we were taught during the advanced class, that we can carry out quality improvements by prioritizing our interventions, which will also help us. Once we get a weighted score, you'll be able to look at the interventions that you can carry out with ease. And then before you can move to the other ones that will require or demand.
I think Lakon's connection is back. I think Mr. Lakon's connection is back, yeah. So can we pick up from where we left off? Let's just give him a few minutes to continue, but I can see that his connection is back on. Thank you, Dr. Adesanya. You can continue, please.
Okay. So using prioritization matrix, and you can see that the highest was improving access to cleaning agents, followed by supervision of health attendants, and then training of environmental cleaning. So using on the right side of your screen. So these interventions were now the ones we now picked, and we started our quality improvements process. Next slide. Next slide.
He's already on the next slide. Okay. I think she wants you to move.
Hello?
Yes, the slide has moved to the IPC improvement process.
Internet is probably very big for me.
Dr. Adesanya, it's showing that you are muted. You are muted.
Yes, I went off. That was what
Okay.
happened. So I was not
All
trying
right.
to connect with another device.
Okay. So, welcome back.
Thank
That's
you, ma'am.
a situation on hand. We pray our internet connectivity will improve.
So I'll just quickly go through it so that before something else happens. So the improvement process, we started with a meeting that is improving the access to cleaning agents, a meeting with the management team. And when we met with them, we resolved that we need to develop a new system for supplying cleaning equipment and agents to the health attendants. Then reducing supplies from monthly supplies to weekly supplies. So we started supply every week instead of the normal monthly supplies that eventually does not get to the end user. Then also during the meeting, we were given the opportunity to work with the procurement team and so that they could provide the cleaning agents, and we also assisted in the placing of orders and all the things. We made a list of the cleaning agents and equipment that we require for the hospital. So those were the ones that they now placed orders on and purchased for the hospital. Next slide. So after doing all that, we went ahead to train the health attendants. We told each unit head to send 2 attendants in their ward and clinic. We did this because we couldn't fund training for all the attendants, but we decided to start with at least 2 in every ward and clinic. And so we started the training of the health attendants, and we also trained our lead as well. So the training focused on processes and procedures in environmental cleaning, proper waste management, hand hygiene practices, and use of personal protective equipment. So the pictures showed when the training was ongoing. Next slide. So this is also the training. You can see where we're looking at hand hygiene, environmental cleaning, and waste segregation. We're teaching waste, we're educating them on the healthcare waste management plan of the hospital, how we wanted waste to be managed in the hospital. Next slide. So the supervision of the health attendants was the next thing. So after training, the meeting with the heads of units, we were able to discuss with them and to encourage them to assist in supervising properly what the health attendants were doing in order to give us good outcome. They themselves complain that they don't even like the situation or the condition of their wards and their clinics. So we asked them that they need to supervise them, that once they get their supplies and they're well supervised, we'll all have a better outcome. So we also requested that our link nurses too, during the training, if the heads of units were not available, they also were going to hold them accountable for supervision of the health attendants. Next slide. So for motivation of staff, after the training, the IPC team, before the training, the IPC team, we presented a proposal to the management to provide a platform for rewarding staff, since they all talked about motivation. So we said that they should be rewarded. And the agreement was that on a monthly basis, we'll give an award and certificate to the cleanest ward. And this will be as a result of the evaluation we will carry out as the IPC team. And we have designed a checklist that we're going to be using to assess them. And with this checklist and the assessment, the ward with the highest score will be given the cleanest ward of the month. And management has agreed with us. We are going to be giving them the certificate. We are going to be giving them an award. And then the management has also added that they will give an undisclosed cash prize to the cleanest ward. And also for motivation, at the end of the training, we gave the link nurses and the health attendants certificates. You can see the CMAP presenting certificate to one of the health attendants when we rounded up the training. Next slide. So in summary, our IPC improvement outcome, we were able to get the following outcomes. Cleaning equipment and agents are readily available, and they are given directly in an estimated quantity weekly to the end users, that's the health attendants. The IPC team are now involved in the procurement of these cleaning agents. Then environmental cleaning has begun to improve in the various units of the hospital following the training. In addition to routine and terminal cleaning, we've also noticed certain wards have started scheduled cleaning, which they were not doing before. Then for waste segregation and disposal, it has also improved. Then our link nurses who have been trained are actually now doing the work, supervising the health attendants in the hospital. And with all the little perks that we added for motivation, we believe that our staffs our health attendants are well motivated. Next slide. So you can see what we were having before. This is just a few pictures of the bad practices that were dirty toilets, overflowing bins. Next slide. And you can also see here that waste segregation was also very poor. Next slide. So here is work in progress. We are having clean, I would say some toilets are clean. We haven't gotten there yet, but we are seeing a difference, and we know that it's a difference that will be sustained, and we are determined as an IPC team to ensure that it is sustained. You can see the wards that they are clean, mopping is done properly using the right agents. Our bins are no longer overflowing because we are working with the team, the health workers that are emptying them regularly. Disposal is properly done now, and you can see that some of our facilities are improving. Cleaning is improving in most of our facilities. Next slide. In conclusion, the IPC team is fully committed to ensuring this improvement process is sustained, and environmental cleaning in the hospital is done properly. We intend to follow through to have optimal outcomes in all units of the hospitals. This will result in a safer and more hygienic environment for patients, staff, and visitors, while also contributing to a more sustainable future. Next slide. So this was after a batch, the training. We did them in batches. So this is a batch of health attendants and link nurses with the IPC team and the CMAC. Next slide. Thank you.
Thank you very much, Dr. Adesanya, for that beautiful presentation and for taking us all to Federal Teaching Hospital, Lokoja. Please, can we give her our reactions? Thank you very much. So for those of us who have questions and comments, I have gone through the chats, but I have not seen questions so far. All I'm seeing are accolades. Let me read up a few. Somebody says, my Chief Ogbonnaya, I remain loyal, 100% excellent delivery, great one. Thank you for a wonderful presentation, Dr. Ogbonnaya. A lot of applause, a lot of commendation, and many hats out to Dr. Adesanya. So I think we have a first question here. It states that, please, can you throw more light on the sustainability plans, especially the cash donation to Cleanest Wards by management? I assume that is for Dr. Adesanya. So I think I also have one for Dr. Ogbonnaya. How often do you advocate that this audit should be carried out at a facility? So you can both start with those questions while we await others. So can we have Dr. Ogbonnaya and then Dr. Adesanya respond in that order, please?
Okay, thank you so much for your question. How often for us, we audit, particularly we do it every 3 months. That is the planned audit, the type that we go to the wards to measure hand hygiene compliance. That is where we have identified a particular period. You know, you have periods, then you have sessions. So we do this every 3 months. That's our schedule. But then we also do routine hand hygiene compliance monitoring. This particular approach, the auditors, they go to a particular ward, they observe a healthcare activity, and they provide immediate feedback to the workers. Maybe if they identify gaps, immediate feedback is provided. We don't use this one to assess compliance rate per se, but it's just for continuous improvement. But the one that has to do with the audit proper, we plan it, and usually we use a whole week, sometimes even 2 weeks, to collect the data, because you cannot really get all the opportunities you aim within a particular period of observation. Our target is 200 opportunities per period of observation. So usually over a period of 2 weeks, the auditors will be going to the particular ward we have targeted for that particular observation period. We'll go there, collect the data, and then we'll be, compiling the data. At the end of that observation period, we will now calculate the compliance. So in that way, we'll be able to compare what we had in the last quarter and what we had in the current quarter to measure if there's any progress. So that is how we do it. Now you can decide in your own facility the frequency, because like now we're supposed to do this August in my center, but we had a challenge and it has not been done. Why? Because the auditor that was supposed to, 2 of them, one of the nurses was transferred to an outpost, so she's not currently in the hospital. The other one is taking exams. They are not seeing whatever one kind of exam they are doing. So they are not available to do that. So we've not been able to implement that this particular quarter. So once they are back, we'll now go ahead and do what we have been doing. The point is that you have to be determined to do it, because it's a cumbersome process. It's not an easy task first. And sometimes some of us, we go there to do it with the nurses, just as a way of encouraging them to collect the data. And once that is done, we are able to compile it and then know the compliance ratings. Thank you, and over.
Thank you, Dr. Ogbonnaya. So the important thing is it has to be done periodically. And even when you have challenges, still ensure that you work around them and conduct it, because you need it to measure your progress over time. So Dr. Adesanya, can you unmute and answer your question?
Yes, thank you, ma'am. And I want to use this opportunity to apologize for my network interruptions. So for sustaining it, actually, our proposal was mainly for us to give a certificate, design a plaque that during monthly we'll identify those words, give them the plaque. But after that month, that plaque moves to the next word that wins the prize based on our evaluation. But our CMAC is actually passionate about this environmental cleaning issue. So he said in addition, he wanted a cash prize. So I believe that the sustenance is at the level of management now. And we're hoping that since they've given the award and our CMD has bought into the issue, actually it has escalated to the board. The board even gave their own final approval that yes, staff should be motivated. And if this is a means of motivating them, then go ahead and do it. So we got that, and that's how we are hoping that once it starts by next month, we will be able to sustain it. And we believe that our CMD, once he puts his mouth to something he wants to do, he always continues that work, and the CMAC is so passionate about it. So, and we also know that these are people, I mean the nurses, when there is something to compete about, everybody wants to put in their best. So it's a win-win situation for us, because we know that now the wards know that there's something coming at the end of the month. So everybody will definitely want to do their best to make sure their unit is the cleanest. And we know that for us in IPC, that is actually what we want, the clean wards. And we hope that will sustain the awards. Thank you.
Thank you very much, Dr. Adesanya. You make all of us feel like moving to FTH Lokoja, so we can benefit from the cash prize that comes alongside. Anyway, here's another comment and question for you. Okay, well done, everyone. Dr. Dan from IHVN. Good to see Dr. Ogbonnaya and Ejembi. Good presentation. Dr. Adesanya, as regards recognition award to healthcare workers, what non-financial incentive can you suggest? He has moved.
Okay, like I said, we are going to be making a plaque which will be designed cleanest ward of the month. So that is a form of incentives. And then for individual staff, so I know that in the corporate society, they do things like putting pictures of the staff of the month or like that in their, probably in their hallway where everybody can appreciate somebody that's done very well. So I believe that is also a non-financial incentive. Thank you.
Okay, that's a very good response, Dr. Dan. I hope you agree with her that the plaque, which be moving from word to word, is a non-financial incentive and can be sustained over time. There's another question here for Dr. Adesanya. I wonder if any data from Dr. Taslim, I wonder if any data or measurements we are taking to show improvement over time, especially since the intervention appears to be hospital-wide. If not, what are your plans?
Sorry, Mark, can you take the question again?
Okay, can you hear me?
Yes, I can hear you now.
Okay, I wonder if any data or measurements we are taking to show improvements over time, especially since the intervention appears to be hospital-wide. If not, what are your plans?
Okay, thank you, ma'am. So what we did was we have a checklist, and we also know that we have the risk assessment tool we actually use the risk assessment tool that's for environmental cleaning, and then we also developed our own checklist. And the checklist now, once we evaluate the ward based on, we have different items that we look at. And when you are with that, the scoring before and after is one we have used. But well, I don't know, Dr. Taslim, if you have other forms of ways in which we can take data, because those are the only two ways in which we used data for this process. Thank you.
Thank you, Dr. Adesanya. I also think, in addition to that, since you've done it before and an after, just the same way we do the hand hygiene compliance, you can do it also quarterly and measure the progress over time. So then you now have a trend analysis that you can use. Dr. Taslim, would you like to add anything to that? You can unmute if you are not satisfied with what we all have said so far, or just to add some more contributions.
Hello, I'm satisfied. Hello, am I audible?
Yes, you're audible.
Yes, I just noticed, I just asked because I noticed that we were all doing so much and there's no data to back it up. So it was just, to push all of us to start documenting things that can be measured, that we can present and people will see that is tangible. So because it's hospital-wide, a lot of work has gone into it. Obviously, there will be results, but how do you formally present these results that people agree that what you have done works? So I think we need to look at such things. Not that I had any particular thing in mind. I was just curious. Thank you.
Okay. Now, I think if you have measurable outcomes, I do a trend analysis. I now do your assessments periodically. I have a trend analysis to show over time from where you were, where you are now, and with also pictures to back your story. That I think that will be a good presentation you can make in any forum. So I see Dr. Kachi's hand is up. Let us take his comments before I continue with some questions from the chat. Dr. Kachi, please.
Okay, good afternoon, everyone. I must commend Dr. Adesanya for a wonderful presentation. Like Dr. John said, he actually took us to your facility. I just want to make it clearer to us and make it a bit smarter that whenever we are having a facility-based presentation, it would be nice that we present this according to the core components of IPC. It will make it very clear to everyone the improvements that we have made in which area. So we know that the first component is IPC program. So we want to know what you have done when it comes to IPC program, the guidelines, what you've done so far, the trainings with the pictures and everything, the multimodal strategy, all those things will just come very clear and very, very smart. So if you did your presentation this way, you'd have been, like I use the word smart, a lot more smarter anyway. So let me just stop for now. Then you talked about environmental cleaning. So cleaning was one of your major high points. So, and you can see now people are really asking, how did you measure? Because if you had brought in this cleaning and you used the multimodal strategy to discuss it, there's a part where you need to do the monitoring and evaluation, and that you'd have just said, oh, CCC. And when you were not answering, that is when we began to hear about risk assessment. We began to hear about tables. You had this whatever chart, but in your presentation, it wasn't there. So it was more of storytelling. That's why somebody had to ask that question. Where is the data? How did you know? The picture is showing some form of improvement, but you'd have itemized, oh, the toilet A was like this and toilet B, okay, there's a checklist to this thing. So what I'm trying to say in essence is let other presentations coming from, facility-based, let's work around the core components of IPC to make the presentations very smart and more like, Then finally, your presentation didn't have any challenges. So I was wondering whether it was just like an easy going thing, SIMAC was just giving for everything, that kind of thing. So I expected to hear some challenges, and that is it for now. Thank you so much.
Thank you for your comments, Dr. Kachi. Dr. Adesanya, would you like to say anything?
Yes, Dr. Kachi, thank you very much. And I've noted it's, yes, we had challenges. That training, I will tell you till now, everything we invested in that training, we have not received the cash back in. We did it as a team. So we had fun challenges. We just wanted to do something because we've been saying IPC, 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 and then we knew that if we don't push, the hospital will not follow through. So we had to come together as a team to put money together and ensure the training, the certificates, everything was done. It wasn't hospital sponsored at all. So that was a challenge. And then the other challenge we had was the fact that we couldn't, also funds was the cost. We can't train everybody. So we just brought in a few people we identified. Then the other challenge we had is that, we are taking the cleaning agents from the hands of a group of healthcare workers, and now we want to take over and ensure that it gets to the end users. So definitely that actually had a little bit of issue. Some people were not happy with us doing that, but we knew that we had something we were going for. And so we had to try and appease them and discuss with them cordially and tell them that we don't have anything against them. It's just that what we want is we want better outcomes. So, and even that was even one of the reasons why we really pushed for the motivation issue, so that they can see that what we're doing is for everybody. Nobody wants to take the glory. So yes, we had those challenges, and we were able to try and overcome them. And like for the funds, we have not received any funds.
Thank you very much, Dr. Adesanya, for those responses. There's another question for challenges, but you've already addressed that. So for Dr. Ogbonnaya, here's another question for you. If frequency of audits is allowed to facilities to determine, to decide its frequency, what happens when the WHO recommendation for at least 200 observations per month isn't met? Does it still hold scientific value for academic purposes?
Thank you very much.
Dr. Ogbonnaya, you're muted. So
I can't do it from here.
no, but you're a co-host, so you should. Excuse me. Mr. Leko, please, can you help us unmute Dr. Ogbonnaya? You're unmuted now.
Can you hear me?
Yes, we can.
Okay, thank you very much. So, yes, the WHO recommendation of 200 opportunities, it's not per month. It's per period of observation. So that's the first point. And assuming we say, okay, we want to use 2 weeks, to represent the period. And then we know the level of healthcare activity that takes place in our world. We'll be able to calculate, our target of opportunity per session. If for any reason we can't meet up with that 200 opportunities, then we can as well extend the time for the observations. It's important because this 200 was agreed on by some scientists and some people who did some statistical thing and came up with that minimum, with that minimum value, because there's really no agreed upon sample size for hand hygiene observation. But they have done some other calculation that are beyond some of us, to arrive at that minimum of 200 for your compliance rate to be valid. So that's the point. So if, for instance, you target, okay, you decide it's 2 weeks or 3 weeks or 4 weeks for a particular period of observation, you work to achieve your 200 opportunities within that. You can get more opportunities, no problem. But for your compliance calculation to be valid, so that you can compare, you can make easy comparison with other observations, then you get to that minimum. So that's the idea, for you to have valid results. So if you observe less than 200 and you now publish it, maybe as a publication, I don't think it may be used as an evidence of what is happening in your, as a valid evidence of what is happening in your facility. So it's best to put in every effort to achieve that 200 minimum opportunities. I think that's what I have to say to that. It's not per month, it's per observation period.
Thank you very much. I'm sure you made the clarification clearly. So I think it's understood. So you can, as you said, we can do your observations maybe beginning of the year, end of the year, or if you can, 3 or 4 times a year at every quarter. But you just aim to achieve 200 observations per period when you are conducting the audit. So thank you very much, Dr. Ogbonnaya. There's a question here for Dr. Adesanya. Do you also advocate for management to renovate and change some of the faulty equipment and the built environment? Because from the pictures, I saw some equipment and built environment looks pretty old. So Dr. Adesanya, please.
Yes, yes, actually, that is an issue on ground, which we have actually discussed and discussed and discussed. So we are just working on making what we have look clean and safe for our patients' use. But you know that when it comes to renovation, a lot of things go into it. It's a capital project. So even if we apply, we talk to them about it until the funds are available for them to renovate. So that's why we decided to, okay, well, since we cannot make them do the changes, although some of the wards are being renovated, but they cannot renovate all, we now said, well, let's try and make what we have very clean. And then that's what we are working on. So I believe that's in the nearest future, once funds are available, it's in a pipeline for innovation.
So thank you very much. So you start where you are and build from there. So Dr. Inua, your hand was up. You can take your comments or your questions. Hello, Dr. Salisu Inua. You can unmute and speak, please. Okay. So do we have any other comments before we wrap up? Okay, yeah, there's some comments in the chat that the link is not working, the link for evaluation, but I think a second link has been sent. So can we please use the new link for our post-session evaluations so that we can improve on our sessions? So do we have other comments before we wrap up today's presentation? Dr. Shiwande, do you have any comments for us, please? The chairman of NSIC.
Well, I should just thank you as a good facilitator and for the presenters, great presentations from both of you, Dr. Ogbonnaya and Dr. Adesanya. But, you know, I really sat down and I'm just listening. M&E is very, very key. And when we're talking M&E, we should be thinking of even looking beyond this forum. I hope we'll be able to at least standardize everything we're doing, make sure it's going to pass through, so that as research, we can actually publish some of these small improvements. It could be local journal, it could be international journals. We should be aiming at that, not just thinking about small improvements. But I know the picture, and I want to say this to Dr. Abimbola Adesanya, that when we're going to do international presentation, please don't use a toilet that doesn't have a cover. I know that it is not your fault, it's the management, but we should try and advocate, at least use one that can be presentable, so that we put our best foot forward. But you're all doing a great job. Keep doing what you're doing, and I'm sure one day we'll get there. Thank you all very much for your time. God bless. Over and out.
Thank you.
So thank you everyone for making out time to be with us today. And we send our utmost thanks and appreciation to Dr. Godswill Ogbonnaya and Dr. Adesanya Abimbola for those wonderful presentations. We also thank our audience for being with us from the onset till this time. And remember, use your data to show the activities you are having at your facilities, so that when we have our local conferences and our international conferences, we will have a lot of representative presentations from Nigeria showing how much we are doing. So let it not just be by words, but by our presentations and scientific papers. We can show that, yes, we are moving. Take out time to fill our evaluation forms. The link is in the chat. And hopefully we will see all of you last Thursday of next month.